Good afternoon, everyone. I hope you've all had a good day, good weekend. And we're here for our fifth installment of updates and question and answers for coronavirus. Thanks to all who have submitted questions. I have a number of questions, very interesting questions. And hopefully I'll be able to provide some good answers for you just in a few moments. Again, as we get started, let me just say a quick word of prayer, then we'll jump right into the discussion. Go ahead. Gracious Heavenly Father, we thank you again for another day and for the guidance and protection that you provided each one of us. We thank you for allowing us to be individuals under your watchful and tender care as opposed to just simple statistics. Be with us as we go through this presentation and discussion. May it provide illuminating understanding and wisdom for us, and we be able to apply this in our lives and to help others. Amen. Okay. So this conversation usually starts with just a review quickly of some of the data and trends in California and Los Angeles County specifically. And then I'll jump right into some of the submitted questions, and we'll have time. I'm sure we'll have time for open questions at the closure of doing the prescribed submitted questions. And again, as a reminder for everybody, just in case there's anyone new on the call, again, it's really important to remember that what's unique about the COVID-19 virus, or nCoV as we call it, is that this novel coronavirus has a fairly long period of time of being asymptomatic, having an extended incubation period, having an extended period of time which you're asymptomatic, and for a lot of people having minimal or mild symptoms whatsoever, and then returning to normal or with minimum symptoms and still being infectious. And so that's very different than many of the other viruses, particularly like the flu virus that we are typically used to. So it's because of this, because it's asymptomatic, because it's actually hanging around, that it can spread throughout the community, and that it will spread in some ways unnoticed, undetected, and therefore it can be around in the community for longer periods of time. And it's why we're likely to have this infectious disease with us for some months to come in one form or another. So again, I just like to remind people about that, because this idea that it's going to go away in the coming weeks is very unlikely, just because of the nature of the virus. And we can talk more about that if you have questions. The overall California trends, I've shown you, this is as of yesterday, late evening yesterday. And you can see that the new cases by day overall are fairly leveled off. But as you can see, every so many days, you'll get this sort of double hump, right? So you can see, as I draw this line here, you can see one line there, and then you can see another line there, which is these two lines just represent leveling off. And as I mentioned before, every several days, we will see sort of like a new level. So we really haven't hit a peak until you don't have this sort of stair stepping that existed before. The first step was a really big step, and then you can see the next step was a small step. And so we'll see over the next several days if we go up again, or if it stays leveled off. The number of deaths by day, again, lag. They typically lag that of the new cases. And again, we won't know whether or not we're going to have a line that goes down, whether we have a line that stays straight, or whether we'll have another hump. Again, it will just take some time before we'll know that. So I try to tell people to be cautiously optimistic, and then we'll see what happens as we likely relax the shelter-in-place order, open up businesses, and people actually get outside enjoying the folk in Huntington Beach. So we'll see a little bit more about that. If you remember, when we began this initial conversation just almost 5 weeks ago, or 4 weeks ago, 4.5 weeks ago, on April 6th, we had 16,000 cases and 385 deaths. And what I'd like to always update you with is where we were then and where we are now. And you can see, that's a pretty big increase, right? That's actually about a threefold increase in the number of cases, but we are testing more people now. But the number of deaths has gone from 385 to almost 2,400. So about a 6 to 7 time fold increase in the number of deaths. And while you can see, again, over here on this chart, we are leveling off in terms of the rate of rise. It just means that the numbers, the rate of numbers are about the same, aren't going up as fast. But we still have new cases and new deaths. So when you flatten the curve, flattening the curve does not mean, even if it was perfectly flat like this, does not mean we don't have any new cases. It doesn't mean that you don't actually have any new deaths. What it means is that the rate of new deaths and the rate of new cases is the same day after day. Okay, so again, very important to know the difference between flattening a curve versus having new cases. Okay, the last observation is that LA County, which is a big city, a really, really big city, and we actually have more people in the city than some states have in their total population. But you can see there are 27,000 cases detected in LA County, and that's actually, you can see just under half of the 58,000 cases confirmed in California as a whole. And again, you can see we have more than half of the deaths in LA County compared to the 2,400 deaths in California. Okay, so again, important to know that LA has a large concentration, LA County has a large concentration of people affected by this disease. This is just a chart I've shown you guys over the last few weeks, just to let you know that if we look at the people who are in the hospital in LA County, it's actually remained fairly flat overall. The top part of the graph are the number of people who are COVID positive confirmed cases that are in the hospital. And you can see it's remained fairly flat, around 15 to 1,600 over the last 2 weeks or so. So that's a good thing, because that means that we don't have new cases that are actually becoming more and more sick and are staying in the hospital for prolonged periods of time. If people are sick, they're either out of the hospital or they actually are going in and out. The majority of people are not staying in the hospital for a long, long, long period of time. And that's actually a good thing. If they were, then this number would be increasing because the longer someone stays, they add to an additional person who stays longer and longer each day. So again, this is good news for the County of Los Angeles. This represents data from 70 different hospitals here in Los Angeles County, and we'll be looking at these numbers very closely to see if they change over the coming weeks when we relax the stay-at-home order. The last thing I want to talk to you about is a report that was published last week by the Department of Public Health. You can find this report on racial, ethnic, and socioeconomic data and strategic recommendations at the California Department of Public Health website, and you can get that information. And what I wanted to just share with you is just some of the data around who, at least in California and specifically in Los Angeles County, are actually getting this disease. And again, this data looks different than, say, for example, Chicago. Remember in Chicago, where we had a disproportionate number of African Americans who were hospitalized and were sick and actually died. Remember, they represented some 70% of the people who had adverse outcomes compared to the population of just around 25 to 30% of the population. We don't see those same breakdowns here. What you see in this first graph, again, in blue are people who are older than 65. In red are those who are aged between 41 and 65. In green are those between age 18 and 40. And what you can see is that the majority of people are red or green, whether you're white, Black, Latino, Asian. The majority of people who are actually getting this disease and have confirmed cases with symptoms are people who are under the age of 65, regardless of race. So again, that's very, very important to note. The second observation is who's being hospitalized. So those are just confirmed cases. And if we look at who's being hospitalized, you can see that everyone's being hospitalized at a fairly high rate. White folk, Caucasians, are actually hospitalized at a higher rate than others. Now, whether that represents health insurance status, whether it represents that they actually are sicker, I don't know. But the next graph actually is helpful to some degree. If you look at this next graph, what it suggests is that those individuals, again, these are individuals who have confirmed cases. And if you look at the proportion and breakdown of this first graph, it looks like they actually match our statistical groups fairly well in terms of the percent of people in the population. The next graph on the bottom, however, is those people who actually have died. So you have the people who have confirmed cases. And if we in fact worry that there is disproportionate share of deaths in African Americans and Latin and Hispanics, so Black or brown communities, well, actually, when you look at the proportion of people who actually are dying from this disease and you add this up, 46 plus 8% is about 54% or so. And if you add that number up, it's in terms of people who died, it's about 50%. So if you look at Black and brown together, we are not overrepresented, if you will, in individuals who are dying from this disease according to our population proportion. And so again, what you've seen in the South and what you've seen in places like Chicago is not necessarily evident here, at least so far based on this data. And again, this is using one outcome, such as death, which is a really important outcome. And that's not to say that this disease isn't hitting our communities very seriously. I'm not trying to minimize that, but I think it is important to recognize that there aren't systematic things in the data that represent disproportionate outcomes. And in fact, if you look at this and look at white Americans actually die at a higher rate, a disproportionately higher rate than they do represent people who have confirmed positive cases. In a similar number, again, 28% people are represented in deaths for white Americans in California and particularly Los Angeles County, compared to 23% in terms of people who actually have positive symptomatic disease. And that's also seen in African Americans, 8.3% represented in the symptomatic pool who are confirmed positive, but about 14% or so in those who die. And so you can see both white and Blacks are overrepresented, if you will, in the death. But as a whole, Black and browns are represented probably just about equal. So I think I wanted to show that because I think that's actually helpful in trying to right size some of the data for Los Angeles County and California compared to the rest of the country. Okay, now that I've done that, I want to just quickly get into some of the questions, some really interesting questions that have come up and that were submitted to me either directly or through the email. The first question is, can mosquitoes transmit COVID-19 infection to humans? This is a really important question, particularly now as we kind of get into the warmer seasons. Mosquitoes are out and about. And the answer, at least official answer from the World Health Organization, is no. Many other infectious disease experts say no. There are some people actually doing, particularly the U.S. agriculture folk who are doing studies to actually further elucidate or test the expert opinions. But the official opinion from Wuhan and those experts in that report, as well as the World Health Organization and many viral and epidemiologic, as well as insect experts, is no. Does that mean absolute zero chance of getting it from a mosquito? Probably not. But again, there's one thing to say that an animal or an insect has it themselves. It's another thing to say that they can transmit a live virus to you that can cause infection. And so far, we have no evidence and not a single report of an insect vector for this disease. The next question was, what do we know about stroke as a presenting symptom in COVID-19 infection? And so I share with you an article that was published last week in the New England Journal of Medicine. It's probably one of the world's top rated medical journals. I get it every week nonstop at my home. And they actually have quite well-respected editors and editorial boards, and are therefore considered to be responsible and credible when they report something. So on April 28th, last week, there was a report, and it was in a report described as a correspondence in this journal. So it wasn't a study, it wasn't controlled. This was someone in New York, very thoughtful physicians in New York who are caring for patients, who decided to write a description of 5 patients who were young who had strokes. It's the devil's in the detail. Again, the way the news gets a hold of this, it's like, oh my God, there are all these patients who are young, who have no other risk factors, who are having strokes from COVID-19. There's something wrong. And then it kind of flourishes over the last week or two. So again, the devil is in the details. But there are 5 patients. There are traditional risk factors for stroke. The most common one that we think about is age, but there are other risk factors such as hypertension, diabetes, and even previous history of stroke. It turns out that 3 of the 5 individuals had risk factors. So they weren't without risk factors. So 3 of the 5 individuals had risk factors. And those risk factors included diabetes, unknown diabetes, which was then determined at the time of hospitalization. Someone else had a history of stroke, and another person had 2 risk factors, one of which was hypertension. Again, we don't know whether it was controlled or not controlled. The other 2 individuals were in their 30s, and as far as we know from the report, they had no known risk factors for stroke. And so what people are talking about is it may be that the infection of the virus is unmasking risk factors which were previously thought rare, or genetic predispositions which were previously thought rare. And we'll actually have to investigate this much more before we know more about this. But this is actually fairly uncommon when you look at the total numbers of patients. And so it is something that people have seen. A good number of those patients with stroke, when you look at other reports, also have risk factors. So there are young people who have stroke who also have risk factors for stroke. That's the majority of them. And there are some who have no known risk factor. What I will say is that these strokes are caused by blood clots, not by plaque. And so that's as important because blood clots can occur when you're sick, and particularly when you have a severe infection. You can get blood clots while you're in the hospital that can cause stroke. So it may not be as nuanced or rare as you may think, but this is something that unless we find other evidence of clots that are higher risk, maybe nothing more than people having blood clot related complications when you're very sick. And so more to follow on that, but it actually represents a nuanced, interesting sort of outcome in this viral illness. I will say that in patients who actually presented with SARS, there was also reports of patients with stroke in SARS as well. Okay, next question. What % of COVID-19 deaths are from non-high risk or non-vulnerable populations? And this is a difficult one to ask. And it's sort of related to the stroke question in some way. It's this concern that people report that lots of people who are at risk and are vulnerable are people who have risk factors that we've talked about: chronic comorbidities, advanced age, and even morbid obesity. And so the question really says, well, if you have none of those things, what's the chance that you can have complications, severe complications, or die? And most of that data actually is very difficult to get. But when we look at states such as New York, where we actually have a longer history and more data, it turns out that that number is probably somewhere between 0.5 and 1%. It's probably too little to be able to get more detail about that. What do I mean by that is, oftentimes we find out more about these patients afterwards in terms of whether they have chronic illness or chronic disease, number one. Number two, obesity, unless you have a complication attached to your obesity, is not listed on your death certificate or a cause of death. So if you actually say, for example, have a BMI of 40, you've never been hospitalized for an obesity-related complication, like heart disease, for example, then your BMI of 40 or 45 will not get listed as a comorbid condition. And so talking to my colleagues looking at what I've seen and taken care of in my home hospitals, that we know in the US, we have certainly younger people who actually have the disease. This slide is from people who actually had case fatality, so meaning that they died from symptomatic COVID disease in China. And what you could see is the largest proportion of people by far were people who were, again, over the age of 65, even over the age of 70. And really, when you start looking to people who are under the age of 50, it's a very small number of people. It's a fraction of a percent. Even when you add up all the fractions of case fatality ratios, it's less than a half of percent. It's just about a half a percent for everyone under 49. And again, it's hard to know exactly what those risk factors were, but they still represent a very rare complication. So I think the message here is that still the majority of people who are having complications from this disease, the vast majority, at least 99 of 100 people who have complications from this disease have some risk factor. They're either advanced stage or they have some chronic comorbidity, including morbid obesity, as complications. The other group that we don't know about are people who might have some problem with their immune system or genetic deficiency, which may otherwise be unmasked by this infection. And again, we'll learn more about that. And the other group I've talked about before are the people who are relatively healthy healthcare workers who actually have died from this illness, who have otherwise been healthy as far as we know. And what we think is their biggest risk is the dose of infection. They're either getting repeat exposures, lots and lots of actually viruses attached to them and infecting them, or they're getting infected over and over again, overwhelming their immune systems. So if you're not a healthcare worker taking care of patients with COVID-19 and you're otherwise healthy, your risk for having complications or dying, either being hospitalized, having complications, or dying from this disease is very low. And it's not as low as probably getting in your car and driving down the street and trying to avoid an accident or a plane ride, but it's actually pretty low. You represent less than 1% of the people who are having this infection. And again, I think it's much lower than even 1%. It's just that we're not well characterizing those individuals who have comorbidities such as obesity, things that affect your lung function, or other things that may be asymptomatic but are actually real diseases, like clotting disorders and other things that may get unmasked when someone gets severely ill or get infected. So more to follow on that, but I hope that answers the question. I think it's important not to minimize the idea that we still have almost 90 to 100 million people who are very susceptible, right? Just based on age, that's 55 million or more individuals in the United States who are over 65, and another 40 million people who have chronic medical conditions who are under 65. So there are 90 million people in the United States who are still at risk for this. And again, if you look at the number of people who've been infected so far with symptomatic disease, we're just at a fraction of this. So we have a long way to go, if you will, for exposure, or lots of susceptible people in the meanwhile while we await getting a vaccine. Now, I will say that the majority of this 90 million people will have mild infection. We know that. Only a fraction of this 90 million people will have severe illness, require hospitalization, or die. Only a fraction. The majority of these individuals will still do just fine, with probably half of them having no symptoms whatsoever, and then some 25 to 30% or more of them having some mild illness that they might dismiss. It's really a fraction of these individuals who will get sick enough to maybe even warrant going to a hospital or take a day off work or stay home, and a fraction of that fraction who will have a risk of being hospitalized and going to the ICU. So again, I hope that puts this in context. For the majority of us who are on this call who are well and healthy, even if we have hypertension, if it's well controlled, even if we have diabetes and it's well controlled, we're in a group of people who have a low risk for complications, a low risk for complications and bad outcome. Someone also asked, what and who are health officers? Okay, how much power do they actually have? So health officers are people who are appointed usually by the public health departments. In California, they report directly to a chief executive. The chief executive is the director of the Department of Public Health, Barbara Ferrer. And Barbara Ferrer has been interviewed a lot on TV and is actually doing a lot of news conferences. Our public health officer is Muntu Davis. There's a picture of him, and he reports directly to her. Now, as a health officer, he's given lots of responsibility for planning, organizing, oversight, etc. However, the health officers rarely make independent decisions, particularly in a public office like this. Many municipalities have a governing board or body or authority. In Los Angeles, we have a board of supervisors, and the public health department reports to the board of supervisors and must get cooperative permission from the board of supervisors before making any declarations or endorsing any orders. It turns out that the health officers cannot direct the governor's orders. The governor's orders actually supersede a health officer. Health officers can actually work at the federal level, at the state level, and the county level, as well as the city level, particularly if it's incorporated. In our case, the Department of Public Health has a Los Angeles County health officer who actually reports to the board of supervisors. And again, the governor's orders are the ones that actually rule in the state. So the highest authority in the state is the governor's orders. And we can be more strict, but we can't be less strict than the governor's orders. I hope that makes sense. Okay, last couple of questions real quick. What is something you wish the average person to know about the virus, but they just don't seem to understand? I have to pause about that because I have a lot of things I wish the average person knew, but I think what I would say, mostly because we still actually have a circus going on, is that I believe that people, if they knew that the stress of this pandemic, the crisis, the news, the circus, etc., particularly at this point, that is continuing to be infused into our psyche, our emotions, and into our physiology, that stress is actually causing you more suffering and more damage than the virus will ever do for the average person by far. There are occasionally people, if you look at the numbers, who are going to get really sick. But the majority of people, therefore the average person, if you will, is going to have much more impact, particularly deleterious impact on their health and well-being, just because of being caught up in the pandemic, the news, their reaction, their emotion, etc. to this. And again, I think by now, 6 weeks into this, 2 months into this, we now know as public citizens everything we really need to know about this virus, what we can do to keep ourselves safe, what we can do to take the necessary precautions in our homes and when we leave our homes. And there's nothing more to know except for when there's a vaccine, and then we can talk about, is the vaccine safe, is it effective, etc. And if there's a therapeutic and you're sick, does it work, is it safe, is it effective? But right now, when we are in our homes or we're going to and fro, we're safe, probably the most important thing we can do is getting back to a positive frame, a positive reframe in terms of the way we frame our thoughts and how we go about our day, and sort of pushing this down, if you will, to where it belongs from a priority standpoint of view, which is, particularly as we open up, pushing it back down to one of those things that we need to pay attention to and be cautious and thoughtful of, but not something that actually will dominate our lives in any preoccupied manner. So that's one thing I wish that people would actually digest and think about. The last question, and I think I've been respectful of everyone who submitted questions, I believe, and if I missed some, in a moment you can ask. The last question I have is, in retrospect, what was something that experts got right, something they got wrong, and something that experts still don't know but would like to know? Well, great question, and it depends on who we're calling experts. So if our president is considered expert, well, he got a lot of stuff wrong. But let's just say we're talking about people who are real experts. So the Dr. Fauci's of the world, the epidemiologists, the virologists, the public health people, the real experts. So what did they get right? I think what they got right overall is the notion that we needed to take some upfront measures to prevent our health systems from being overran throughout the country. I think that if we did not do at least a early shelter in place, put in a lot of the mitigating mandatory recommendations at the state and local levels, if we did not do that, at least for some period of time, we would be looking at disasters and crises all over the country, as we would have had so many more people in our hospitals without the resources to care for them. So I think they got that right, acting on that. Could they have done that a little sooner? Sure. But they could have actually not done it at all, or waited a lot longer. So I think they got that right. Something they got wrong, I think the biggest thing that they got wrong, that we're still getting wrong, is actually testing. And there are two things related to testing that we still just have not done well. One is the actual testing kits, the testing reagents, et cetera. While we're ramping that up, we still don't even have enough swabs. And the president and the White House, as well as other people who are influencing that, have not really pushed this agenda, because we really do need to test more. And we need to test more and fortify our public health system with the infrastructure and support so that we can test and isolate. That will actually inform us and allow us to make better decisions. So we did not get that right at all. Per capita, we are not testing at the rates of many other countries. And so I think that's one thing that we've gotten wrong. And one thing that we still don't know is we don't know whether a vaccine, even if we develop a vaccine, if it will work. Now, what do I mean by that? We know that for other viruses, particularly cold viruses, that people have attempted to develop vaccines in the past for, that they just don't work. The immunity that actually is incurred by exposing someone to a vaccine, you really need for that to last for a while. So when I give you a vaccine, think about your vaccine for measles, mumps, or rubella. We got those as kids. None of us have gotten boosters for that. It's because our immunity is nearly lifelong. And that's an ideal vaccine, something that you can identify, you can expose a person to, and then you're good, you're protected for decades and decades and decades. So you still have measles, believe it or not, in other parts of the world. But if you travel to an endemic area of the world where there's measles and you've got the measles vaccine, you're safe. That's what you really ideally want for a vaccine. We don't know whether or not that's going to work, because we don't know if we have really prolonged immunity attached to this virus. And in fact, some of our earlier data suggests that we will not have prolonged immunity, that in fact, looks like the immunity may last months as opposed to years. But again, time will tell, and we'll figure that out. Nonetheless, we will not have an answer for that probably for at least, in terms of a firm, reliable answer, probably for another year. And so that's something we still don't know, whether or not the vaccine will really work. But in the absence of that, remember what I say, you need three things to say you have something under control. You need to be able to diagnose it readily, effectively. So that's a testing, equipment, and availability. We don't quite have that yet. Number two, you have to have effective therapy. Once you get it, we actually have to be able to treat it. And then third, if applicable, a vaccine. Right now, we have only a fraction of the testing. We do not have effective therapy. All of our therapy is sort of supportive at best, and we do not have a vaccine. And it's because of this and the type of natural history of this virus that I believe COVID-19 is going to be COVID-20 and maybe even COVID-21. The only hope that we have is that this virus will burn out in the heat of the summer. But I would not keep my fingers crossed for that. Okay, let's get to questions online. We'll actually spend 10 minutes if people have real-time questions or so. All right?
Daryl?
I'm here, I'm listening.
I heard today that Pfizer do have some sort of immunity or injection have taken it, but they still it'll be like till September. Do you know the results? Pfizer, did you hear about that?
He had COVID. He was out.
Yeah, so that's a good question. And so there are a number of companies that are very quickly trying to come up with a therapeutic. We don't know whether or not the therapeutics will work yet. So they will have finished some of their early studies by early fall, and then they'll be able to know whether or not it works. So what Pfizer is basically saying, hey, we have some drugs. Some of these drugs are retroviral drugs, drugs that have been associated with antiviral therapy. We've used some of them for HIV even, right? And because HIV is an RNA virus and COVID-19 is an RNA virus, we are actually looking at drugs that already are used for RNA viruses, okay? So what they're doing now is trying to rapidly study drugs that already are in existence or drugs that are tweaked just a little bit pharmacologically to see if they'll work for COVID-19. And we won't know that for a few months, right? You actually have to come up with some safety. That's not really a big issue. If the drugs are already available in use, we know that they're safe. But then you actually have to come up with finding the right dose. That takes a little time. And then you have to decide whether or not it really works. And it doesn't work on enough people. So that takes some time. So it's May. I would say 3 to 4 months is a really fast turnaround time to get that sort of data, reliable data anyway. And so we'll see. We'll see. We already know what happens sometimes with making early predictions. Some of this you have to be very careful. Pfizer is a global pharmaceutical company. I know a little bit about pharmaceutical companies. And oftentimes news of a pharmaceutical company having a cure for something is nothing more than something to help their stock price. So you have to be very careful about these sorts of claims and just have to wait until the data comes out. Okay?
Okay.
Good question. What else?
I heard on the news this morning, oh, this is Sharon. I heard on the news this morning something about the virus mutating. Were they saying that it had already mutated before it left China or is mutating now? Did you hear anything about that?
Yeah, so that's a very important question. One of the things I always like to remind people is that viruses are living organisms, right? Like me, like you. And what we would like to do is survive, right? We want to survive as much as we can, any way we can. And so usually when you see mutations occur in the context of two situations. One, when it's just what we call a point or rare episodic mutation, which actually occurs with us. A lot of cancer that we have is just our cells healing or dividing over and over again, which happens every day. And then something in that machinery goes wrong and you get a mutation that then becomes cancer. So that can happen to viruses as well. And that will happen almost in any living organism. That's one. So sticking around, living long enough, you will get mutations. Whether that mutation survives or not is a different story. That's competitive advantage, etc. So that's one reason. The second reason you get mutations is because it's just trying to survive. And that usually happens when you're getting a therapeutic class trying to treat it. So in HIV, for example, when HIV came about in the 80s and in the late 80s, we only had AZT, if you all remember. Well, very soon, we actually were no longer able to use AZT because there was AZT resistance. And the AZT resistance for HIV was because the viruses began to mutate. And so the other reasons why you get mutation is because you actually have effective therapies and the virus is just trying to survive. The reason why we have mutations right now for COVID-19 are sort of sporadic mutations more than anything else. And we know that there are there's a family of coronaviruses, a large family of coronaviruses, hundreds of different viruses, if you will. And then the coronavirus 19, while there are several different viruses, there are two dominant viruses, two dominant strains that left China, 2. And those are the same 2 that we're dealing with. We're not dealing with a third, a fourth, a fifth. You're going to always see over time small changes in viruses. The question about whether that is important or not is whether it actually causes resistance to therapy, or if it actually causes different disease. And so far right now, these 2 strains that we have are the same strains that left China. One strain causes actually more mild disease, and one strain causes more severe disease, meaning more severe respiratory illness, leading to acute respiratory distress syndrome, etc. So this is something that we've known for a while. People are beginning to talk a little bit more about it, because as we begin to talk about therapeutics, people are concerned about mutations, etc. So not much more to it than that. I would not worry more about this than any other RNA virus, because by nature, RNA viruses will evolve very quickly. That's the nature of an RNA virus, just as they replicate and sort of move through their life cycle. You will get changes, little mutations in them as well. But in terms of mutations that affect us clinically, only 2 main mutations that are clinically relevant right now.
Hey, Chief, or Dr. Harrington, excuse me. I have a woman who calls herself my wife, and she practices in the dental field and is faced with some challenge of these offices opening and going back to work. So this is sort of on her behalf, but partly for my education as well. Should they be treating, and by they, I mean the hygienists primarily, patients, dental patients who are known to have the virus, the belief being that as they perform their treatment, there's aerosol that's generated. And if they're working in rooms that are not the most ventilated, then maybe that poses some risk. So should they be treating those patients? And then also speak to, in the process of doing their procedures and generating this aerosol, how much or to what degree would they have to consume these droplets or the aerosolization of the virus in order to be infected? If that's something that can be, a quantity can be put on that. I don't know if that's a good question.
No.
Phrase that.
It's a good question. It requires me to be endowed with other faculties and knowledge than I think are earthly possible.
That's right.
So the latter part of the question is, who knows? But if you're a person performing an aerosolizing procedure, let's just assume that the amount of virus, if present for that individual, you'll have more than adequate exposure for. Okay, so you can't quantitate that, but if you're doing an aerosolizing procedure in someone who's infected, and the material that's being aerosolized is infected, you'll have more than ample opportunity to get infected yourself. So the first question really is, what's the risk? And the risk is, answer is simple. It's increased, but whether it's increased minimally or a lot depends on knowledge and what we call personal protection equipment, right? Your protection. So the knowledge part is, are we aware of whether or not the patients we're working on have infection or not?
Assuming yes.
So the reason why I'm starting with that is because we don't know if asymptomatic people are going to be tested, and we don't know if dental offices are going to require every patient to be tested before they come. Right. So let's just have 2 scenarios. If it's a scenario where they're not requiring people to be tested before they come, and they're just actually doing fever, temperatures, etc., then it is possible that you have people who have asymptomatic infection who are going to have dental cleaning procedures, etc. I think if you're asymptomatic and you don't have a fever, the chance of you actually having a large burden of disease is fairly low. Having said that, if you're actually with somebody for 30 minutes or an hour and you're inhaling aerosolized material, or the aerosolized material is being in contact with your mucous membranes, you might have an increased risk. So the reason why I say that, Derek, is because the answer should be the same, whether you are a known infected patient, right, a known previously infected patient, or an unknown patient. Assume everyone is infected. And if that's the case, unless you know for sure someone is not infected, then the only way to really minimize your risk is to maximize your protection.
Yep.
And the way you maximize your protection is, at a minimum, making sure you have a face shield, ideally goggles,
Yep.
as opposed to a face shield. If
Both.
I were a dental hygienist, I would have goggles and a shield, okay? And then having a well-fit, fresh N95 mask. That's it. I think I would also, if I were a dental hygienist or working in contact doing this, I would actually make sure I have a gown.
Yep.
And the gown likely would be probably a cloth gown, because you would go through so many disposable gowns going from room to room. It may not be possible. But the point is I would make sure that I'm completely covered.
Right.
And when I go home, I would take my smock and things off and dispose of them in the garage. And whether you change into something else more convenient before coming to the house, or you come in a la carte, depending on the relationship and the household rules. But I would leave that stuff out
Right.
in the garage and would not bring that into the household.
Thank you.
Yeah.
I think that's her showing up, so I gotta go.
Okay.
I had a quick question.
Sure.
You know, and it's just something that I heard today. I guess I was looking at one of the videos, the new risk that they were talking about with regards to the children between 2 and 19, the symptoms, the stomach ache, and what was the other one? Fever and rash.
Yeah.
And so do you know any more about the incidents for now children, as they're saying that they're thinking about letting the smaller children or the school age children go back to school, but holding off on the college students now that we're seeing this? And I don't know if that's a New York thing or if this is something that is could be an issue.
Yeah, so Andy, that's a really important question. So what I want to make sure everyone remembers is that, like many diseases, right? When you see something the first time, you characterize it based on what's most common, right? And that's what's perpetuated in the knowledge and the discussion. And so what was perpetuated mostly when we first saw this disease, right, was fever, cough, dry cough often, and shortness of breath, right? But over time, as we've gotten more experience and we've seen more people, not just the people who are coming to the hospital who are sick, but we're beginning to get reports of all the people that we sent away who had symptoms were not sick enough to come to get admitted to the hospital, right? And so now we're getting that information, and that's where all this information is coming from. Well, I'll tell you that a virus causing a rash is extremely common. It's very common. Right. And so this is not different than a lot of other viral illnesses. The fact that we're now seeing it with COVID is no real surprise. What I think is more important is this notion that we're beginning to see a variety of mild symptoms that people have who might otherwise say it's unnoticed, right? Who may not otherwise have major complications. So this is important because now there are just other signals for people having maybe mild symptoms. And we know that if they have mild symptoms, they still are very contagious. So I think that that's really all it is. I think that this is not something new. I think it's something that we just didn't capture because we're focused on the really sick people. Now that we're looking also at the people who aren't as sick, the people who are coming to clinics, the people who are calling their doctor with telehealth and saying like, doctor, what's this rash? I've never had a rash before. And they're testing them, they're finding out they're COVID positive. We're beginning to see the spectrum of this disease. What you can be reassured of still though, is as the question was answered earlier, the vast majority of people who are becoming sick, incapacitated, hospitalized, and dying, still, when I say vast majority, I'm talking about 99% of the people likely, okay, are people who actually have chronic illness and have advanced age. So college students who are not healthcare workers, who have casual contact and casual exposure are either going to have no symptoms whatsoever, or they're going to have mild symptoms. And at worst, they may miss a day or two out. The worst that's going to happen with that student is that they're going to infect somebody else who may or may not have risk. That's the biggest risk of our kids going to school, is that they pick it up from somebody else and then they take it home to someone who is more vulnerable at risk. That's the biggest risk. But what I will say is that's unavoidable. That is unavoidable. At some point, that's going to happen. And the biggest lesson that we can have as we plan to move forward, the biggest lesson is what we can do to help or ensure that people who are vulnerable and at risk will protect themselves. So in other words, my kids are back at school and I'm making sure that I protect myself from my kid, because my kids are going to be doing whatever when they're at school. They're going to see whoever, they're going to do. Same thing in the school. How are the professors who might be older and at risk going to protect themselves from a classroom of students? Do they just stay in Zoom, remote learning, or do they take measures to prevent themselves from getting exposed or minimizing exposure with in-person classrooms, right? So these are the things that people are going to have to talk about. But inevitably, invariably, our kids will go back to congregate settings, be it education, school, be it kindergarten, be it whatever it is. And like many things, they're relatively asymptomatic and they're going to spread it to us. And what we have to do is just be more cautious. We all know when we were raising kids or around small kids, our kids would be at daycare. And then while your kids were in daycare, you stayed sick, like for 3 years, 4 years. You had a cold. Okay? Your kids were doing great, little sniffle, but you'd be down for the count. It's the same thing. We didn't think too much about it because it was just a cold. Now, instead, you might protect yourself a little bit more rigorously. Be a little more vigilant about the kid washing their hands, about the contact they have, maybe even having the kid wearing masks in the household when they come home. A variety of things are things that we have to think about to protect ourselves if we're vulnerable. Any other questions?
Yeah, Chief, we've heard a little bit or quite a bit about the PPE and whatnot, but we know that, I think you've said before, there are lots of viruses out there. And maybe you've addressed this on some level, but please remind us and speak to how do we sort of internally prepare ourselves for, you know, those of us who I think, as you referenced, are relatively healthy, who are on the call, though we're still at risk, but what can we do internally to prepare ourselves to have a good immune system to be able to resist if we just get some exposure, but not a healthy dose of exposure to the virus? What are some of the things that we can do to make sure that we're prepared for going out as the states open up to deal with this virus or in viruses to come that we don't know of as of yet?
Yeah, so, you know, Derek, really important question, particularly whether we're talking about this COVID-19 pandemic or not. And, you know, it's interesting, last week I was thinking, you know, I know Pam and the health ministry team is on, but, you know, we can think about how we transition these weekly calls to talking about health in general and talking about well-being and how we actually even deal with some of our chronic illnesses. You know, this opportunity and venue has allowed us to, you know, create a platform to talk more routinely. And so we can think about how we exploit this, you know, medium to have those sort of conversations. And you just reminded me of that because the questions you asked is broader than COVID-19. So, you know, our immune systems are quite spectacular. Most of the time they operate in the background without us thinking about them. But we know a lot of things impact our immune system. And when I talk about immune system, I like to talk about, you know, basically how we feed our immune system. And feeding our immune system is not much like feeding ourselves otherwise. And what we feed ourselves with will affect our immune system. So let's talk about the appetites we have and how we nourish ourselves. So nutrition, true nutrition in terms of the food you consume will make a difference in your immune system. Sister Ahana, if she's on the line, she knows that refined foods, starches, simple sugars, etc., all the refined and hyper-processed foods actually work havoc on our immune system as well as many other aspects of our bodies. And so one of the things that we can do for sure is to remove or minimize the amount of refined sugar and processed foods from our diets. So that's an easy thing. We have lots of data to support that refined sugars and processed foods impact natural killer cells, which are really the soldiers, if you will, with AK-47s on the front line, killing things for us. And when we, have basically a nutritive environment circulating in our bloodstream and our cells that are feeding our cells with the poisonous of processed food and sugars, we're basically are taking the bullets out of the AK-47s of our in-case sort of natural killer cell soldiers. So it's really, really important to think about that. So avoiding that sort of nutrition, bad nutrition. The other sorts of things that we feed ourselves have to do with our attention. Our attention food is sort of what I talked about earlier, and that's directly associated with stress. And so remember how we feed our mind, how we allow the negative things to come in to us consciously and subconsciously causes chronic stress. And while acute stress is very important in being sort of safeguarded or outrunning a saber-toothed tiger, chronic stress is not. And chronic stress has been shown with high cortisol levels to impair the immune system. So our mental health and mental well-being, even when we think we're being engaged or active, even when we think that we are researching something or exploring something, remember that if the underlying content there is one of either anxiety, one of stress, one of fear, that is actually increasing your body's level of cortisol. That cortisol is actually impairing your white blood cell function, along with a number of other things that are important in your immune system. Well documented scientifically, not a question. The third most important thing we can do to our immune system, science-driven, anyone want articles on this, I can give it to you, that's been proven that we can feed ourselves with, is not hokey, but it's really important. And that's actually mindset, which is different than what we put into ourselves. It's actually mindset. And it's actually having a mindset of gratitude. So Vina's on the call. Vina knows this fairly well as a behavioral health individual, but having a disposition of gratitude, practicing gratitude. And that means actually feeling, right? Deeply feeling the thankfulness. It's not just saying, hey, thank you, Derek, for asking such a good question. It's actually before the words or the thought even goes beyond that, really experiencing what it means to have you make that impact for me. For example, really feeling the value that it provides me, the gift it provides me, or the sacrifice you've made, and feeling that deeply. That's what gratitude is. And there's very good science around the practice of gratitude, improving health and well-being and the function of our immune system. So those are three things that we can do. Yeah, I mean, we could take a little bit of vitamin C, that's a balanced diet. You could probably take some lysine. You could probably do a few things. But the three things I told you are more important than anything else, I guarantee you, that you can come up with to try to keep yourself healthy and where and sort of ward off, if you will, the sort of elements that typically attack a weakened immune system. Okay? Long answer, but that's true. .
So, Daryl, this is Vina. I am on the call.
Good.
And I do keep a gratitude jar. Anybody, I recommend for anybody on here to keep a gratitude, happiness, joy jar. It really does work to reflect on all the blessings that God has given us, especially during these challenging times. But my question for you is, it kind of relates back to what Andy was saying about some of the new research with children. And I think it came out from the UK first, and then today it was reported on in New York about kids with the inflammation and presenting with like Kawasaki's disease. And I know you had mentioned something about that the virus might be unmasking comorbidities, like unmasking an underlying illness. And I have some friends that are very afraid to send their kids back to school because of that. And these are highly educated people, people who even have backgrounds in medicine, who recognize that, yes, the percentage of people who get really sick and die that don't have any comorbidities or high risk factors is really low. But for them, it's like, do I take that risk that it is really low? Do I want to be one of those 71,000 people today at 1%? What is that number? Do I want to be one? Do I want to be part of that 1%? Do I want to put myself at risk? So what kind of advice would you have for families who are really struggling with that?
Yeah, so it's a really important question, because I think fear is real, right? Fear is not made up. It's a real experience someone is having, and it's based on some reality that they are experiencing. And you can't talk someone out of that. You can't rationalize fear, even though individuals try to do that. But what you can do, I think, is still try to provide information or knowledge. People will choose to use it any way that they want. And then the second part of it is, and you know this in behavioral health, if you're talking to individual people, is to try to understand better what the basis of their fear is. And oftentimes when you have a fear of loss, the fear is rooted in prior loss. You know that. And so you can't have a sort of behavioral health conversation with everybody, because everyone isn't trained to do that. And we may not even have the insight or time to do that. But this is what makes it so difficult, is that, you know, this sort of fear is rooted deeply in things that are beyond just the superficial. What I will say, that if we talk about the numbers, I think it's actually probably an overestimate by order of magnitude to even talk about 1% of people are otherwise healthy, who actually, you know, have complications, require hospitalization, and all sorts of stuff. I think it's a fraction of percent when you really look at the numbers. If you look at the numbers in New York, where we actually have, you know, data on record of some 30-something thousand people, for example, they were able to find like 12 people that seemingly have nothing else going on, right? And so you can just do that math, and that's 12 people is a very generous number, and it's a fraction of a fraction percent, right? So I think where we could give some people some numbers so that even 1% gets smaller and smaller, I think that's helpful, because 1 in 100 is still a large number for people. When you start getting to 1 in 1,000 or 1 in 10,000, and this is probably somewhere around 1 in 5,000, that's the real number, or 1 in 3,000, then I think people can get a better grip on that. That's one thing I'd say. The second thing is, I would say that a lot of these illnesses and presentations that people have, like you talked about Kawasaki's disease, etc., as I was just mentioning before, they have existed associated with viral illnesses for decades. It's actually not new. So Kawasaki's disease is well established. Look it up. There are different manifestations of Kawasaki's disease that can affect the heart, etc. Kawasaki's disease that can cause encephalitis. There's a variety of things, but the majority of people with Kawasaki's disease have a fairly superficial illness, disease that goes away, never heard of again. And the most common cause of Kawasaki's that we see are infections. And you can have viral or Kawasaki's-like illness with viral or bacterial illnesses. Hand, foot, and mouth disease, right? Which we see in babies and kids all the time. What I'm getting at is that a virus has what we call viral syndromes. And of the viral syndromes include flu-like illness, which is what was killing people here because it was a more severe flu-like illness, but also includes, which is severe flu, but it also includes benign flu-like illness like fever, cold, rhinorrhea, and cough, right? Which most people have had that multiple times a year as a cold. And then there are all the other things. We're going to hear, I guarantee, reports of people with encephalitis from COVID-19 because it's a virus. It's going to be a small number of people with that. We're going to see these people with these rashes. And again, we see viruses causing these rashes, Kawasaki's disease. There's a whole long list, if you were to look up viral syndromes, that already exist, and they're not new with COVID-19. And almost all of them, which currently exist, still recover without consequence. So particularly, this is pertinent to Andy's question, particularly the young people, the kids who have this. Many of these kids will have these viral syndromes and illnesses, rashes, and a variety of other things, and that will be it. And we'll just know that they actually have it. So the real news is, instead of just saying, hey, it's Kawasaki's disease caused by something else, now we're saying, hey, that patient, that kid may have Kawasaki's disease and they can have COVID-19. So now we have, the way we should be looking at this is we have another differential diagnosis of Kawasaki's disease. Does that make sense? It's not right. It's not like, oh, COVID-19 is causing Kawasaki's disease. No, we have another thing on the differential, right?
Gotcha.
It's just like if someone said, you have the flu, Daryl. Well, in November of this year, when I come in with fever, cough, my list of things that can cause fever and cough is already this long. It will also it'll be added, something else will be added to it. It'll be COVID-19, right? It doesn't mean it's 100% COVID-19. It doesn't mean that COVID-19 causes all fever and cough, right? But what I'll tell you to this end, if I look at the majority of people in the ICUs in Los Angeles County right now, the majority of people in ICUs right now who are on ventilators, do not have COVID-19. They have other illnesses, okay? The majority of people in the ICU in Los Angeles County, and I know the data because I look at it every morning, are non-COVID-19 patients. COVID-19 is on the differential for a lot of those patients when they come in the door, but then their test comes back negative and we start looking at something else, okay? So I think that we have to put this disease in context to as much as possible, but recognize that these are realistic fears and concerns that are oftentimes rooted in people's history or their trauma or their real sense of potential loss, that is right in front of them or facing them. So that's a very hard thing, but I try to, validate them as much as possible, and then try to provide the information in the right context that might help them come up with a different assessment.
Thank you.
That's the best I got. Yeah.
Excellent. Thank you.
Dr. Harrington,
Yeah.
does the A1C level of diabetics factor into them contacting this the COVID-19 more so than maybe like a person who has type 2 diabetes?
Yeah. So let me make sure I understand. Does the level of hemoglobin A1C, which reflects the level of control, influence someone getting COVID-19? I think that's your question. And whether you're a type 1 or a type 2, we don't have any data yet to separate types of diabetes and risk for COVID-19. What we do know is that diabetes itself is a risk factor. We don't have enough information to know whether or not people who are well controlled versus people who are out of control have a higher risk. But most of our common sense tells us that if you are out of control, meaning you have a higher hemoglobin A1C, that you likely have a higher risk for having complications. So let's separate the question though into two parts quickly: risk of getting infected versus complication. So your risk for getting infected is your risk of getting infected. It's going to change whether you have diabetes or not. It's going to be based on your exposure. Your risk of having complication, which is now that you're infected, now you have symptoms or you become hospitalized, now are attached to your comorbidities. So just because you're a human being breathing and you're exposed to the virus, you have a risk of infection. Your risk of having complications is now more attached to your, duration of exposure, your susceptibility of complications like out of control diabetes, for example. So your diabetes, hemoglobin A1C, is much more likely, like in other illnesses, to give you a higher risk of complications from a disease. It does not per se change your risk of getting an infection one way or the other. Your exposure is your risk of infection. Your
Okay.
complication rate is your underlying disease. Okay.
Oh, okay. Thank you.
Yep. Okay, we'll take one more question, and then we will come to a close for our 5th installment and get something to eat. Well, at least for me, I haven't eaten yet. Okay, what do we say here?
So you're saying that if I am maintaining my good health and keeping my exposure levels very low, keeping a good, grateful mindset, and maintaining my faith in God, that while these states are reopening, I can go out in the public with my gloves and my mask, touching as few things as possible, and sanitizing, etc. when I come home, that my chance of being infected by the virus, again, maintaining a low exposure as much as I know to do, are very much on the low side.
That's a lot of ifs there, my friend. So again, I think Donna asked a really important question. Let's always separate infection from complication.
Yeah. So I'm saying, considering
so what
I
I
don't have
just
any complications and infections or anything else.
No.
Okay.
Well, I'm saying complication from the disease versus getting infected. So when we talk about your immune system being healthy, it doesn't prevent you from being exposed.
Right.
Okay. It actually tries to lower your risk of complications. Right. So all those things that you mentioned will reduce your risk of complication. I think the chances that people will eliminate the risk of getting an infection if they open the world back up, so to speak, are next
more likely than not.
So I think that most people who go out and have to work, have to now commingle with people, you go to the restaurant, so you open up and you start doing things, even if you're wearing a mask, you're going to still have a significant risk of getting infected. The only way you minimize that risk is remain a hermit, which is not practical. Right. Okay. So I think that, when they open things back up, they're going to still recommend physical distancing. They're going to still represent wearing a mask in public. Okay. Wherever you go, the servers and employees are going to be wearing a mask, and they're going to be doing hand hygiene, all that stuff. All that's going to happen. I think that we're going to still have new infections. Okay, at the same or even higher rate. I think we're going to still have infections. Because it's hard to sterilize an environment. It's hard to bubble-proof yourself from an airborne illness or from an illness that is droplets. Right? It's just not possible. The only way you can do that is if you stay in a bubble. So your risk of getting infected will be smaller, but it's still there. For sure. Your risk of having complications from your infection will be as low as possible if you do those things.
Okay, got it. So no need to be fearful being out during this second wave as they are opening things up.
No, and I'm going to tell you, I'll give a personal disclosure.
Okay.
So, and I'm warning you, Derek, specifically, like I've been writing like a machine lately. I've been
Okay.
writing a lot. Okay.
Not that
And
many
when I
cars
first
out
started,
there.
well, not too many cars, but just, I've had flexible time and
Okay.
just trying to get back into it, because it's just a source of meditation for me. And
Right.
I used to ride 5 or 6 days a week, and then I got to the
Right.
point where it could be a week or 2 weeks and not ride at all.
Right.
So now I'm riding. I'm riding almost, every day, finding
Okay.
ways to ride. And when I first started riding more consistently a few weeks ago, I had a mask on,
Wow.
and all that. And
That's tough.
part of that was precaution.
Okay.
Part of that was unrealistic concern or fear. And then part of it was I didn't want to have to deal with other people on the road who are looking at me like I'm crazy because I don't have a mask on.
Okay.
I would say the last week and a half on the bike,
Okay.
no mask, no
Yeah.
nothing.
Yeah.
And do I feel like I'm at a higher risk of getting infected or less risk of infected? No. I have a higher risk of getting infected by far going back and forth to work
Right.
than I do by hundreds of orders of magnitude than going on a bike ride. Okay.
Okay.
So like made no sense just from that
Right.
standpoint. If I was really trying to prevent getting infected in that regard, I shouldn't even go to work. But
Okay.
doctor, I got to work. So that's one thing that I think is important. The second is that, again, I'm paying attention. I'm feeding myself. I'm staying healthy.
Right.
And those are the things, the very things that are going to reduce my risk of complications. And so I decided when I was on the bike, I had mucus, you're sweating, all this sort of stuff is
Right.
happening. It's all in the mask. And it's exfoliating, it's perspiring, all the stuff is coming out. That's what your body's designed to do. And I was keeping it all in.
Okay.
Again, counterintuitive, didn't make any sense. So
Okay.
I think when you start asking yourselves what's your risk, practically speaking, if you're working every day,
Right.
and I understand you've been going back and forth to work
Every day. Every day.
Yeah, your risk, even though you're doing all those precautions, cumulative risk is higher with you going back and forth to work every day just because you're seeing different people, you have these exchanges, you have uncontrolled variables in your environment, et cetera, even though you're trying to mitigate that.
Right.
I guarantee you, you're doing all the right things, but you can't make your risk zero no matter what.
Right.
Right. So
Yep.
I would accept that and just do the things that keep you at a low risk
Right.
of having complications, which
Right.
are the things we talked about.
Yep.
Yeah.
Thank you.
And this is going to be here. Let me mark my words. This is going to be with us around unless something dramatically happens in the summer with the heat. Say we have a heat wave and something severely happens, unless that happens, which I doubt. This is going to be here for a year plus. I guarantee you. So think about this as the way you're approaching this from your mindset and everything in your behaviors. What can you sustain for a year, right? What's realistic to do for a year? That's like a plane. I travel a lot, used to travel a lot until this. And I was in a plane, multiple times a month. And I hear about a plane crash, okay, that killed everybody aboard. How long can I avoid taking a plane trip if that's my job, right? It's the same thing that if you pay attention to the news with regard to car crashes, there are a bunch of car crashes every day, right? But we all get in our cars every day, buckle up, say our prayer, start our motors, and drive on. Knowing that there is a finite risk. So what I'm trying to say is, like looking both ways, looking in the rearview mirror, saying your prayer, doing the things that you know are important, that are worthwhile, and being careful. We all then step out on faith, get in our cars and drive every day, and we work. And that's what this is going to be with COVID-19. We're going to do those things which we know are safe and mitigating and important, and then we're going to function. We're going to go back to the sort of things that we need to do in our lives that make us human, that make us productive, that edify us and actually help us to grow and contribute while trying to minimize the risk. But the risks will just become one of those background risk levels that we deal with, like traveling in a car or anything else. Okay. Great questions, everyone. Tremendous questions, tremendous conversation. It's always shocks me when I look at the time, how quickly the time goes until the hour. Now we're at the 90-minute mark almost. But I've enjoyed every moment with you all, and I hope you all have learned something, and I hope it's been useful. Continue to send in questions. Let Dave or Pam know suggestions, or you can let me know directly if there's suggestions about ways we can do this differently or better, particularly for you. And we'll try our best to accommodate. I'm happy to continue to help and provide, this support and sharing in any way I can. So again, thank you all, and I hope this was useful. And I'll close this out with a quick word of prayer. And we'll see you all next week. Bow your heads. Gracious Heavenly Father, we thank you again for allowing us to spend time together to share, to be curious, to be vulnerable in our question answering. I appreciate and thank you for the blessing and gifts of understanding that I've been able to help others on this call with furthering their understanding so that they may practice and live in a more safe and whole manner as we continue through this crisis. We ask now in a special way that you guide and protect us until we meet again. Keep us faithful, keep us enduring in our efforts, keep us disciplined in our efforts, that we prioritize the faithfulness and the gratefulness that is only ours because we know who is our master. In Jesus' name I pray, amen. Okay. Thank you all, and talk to you next week.
Thank you.
Okay, thank you to everybody who attended. And remember, the questions are recorded online, and also the past sessions are recorded online. And happy Nurses Week, Joanna and Jackie.